nice gift. So I keep muting myself to cough. Anyway, thank you everyone for coming. Super excited to talk to you about clinical reasoning and DDX, which is our new AI-based case simulator. And super excited also to be here with Andrew and Saud. You want to go to the next slide there, Brenna? Awesome. Uh, yeah, so let's go left to right. Saud, do you want to introduce yourself?
Sure. Hey, everybody. I'm Saud. I'm one of the co-founders here at Sketchy. Um, I went to med school at UCI. That's where we started this whole thing. I then went to do my residency in emergency medicine at GW. And then after wrapping that up, worked a bit clinically and spent kind of most of my time at Sketchy, most recently on DDX. So excited to talk to you about that today. I'll pass it over to Ben.
Hey everyone, I'm Ben. I'm the Chief Content Officer here. Went to med school at Columbia. Started my urology residency at UCLA, but the asterisk is there because a year in I realized that I would rather make cartoons for you all instead of placing difficult Foley catheters. I'll toss it to Andrew.
Hey, sorry about that. I'm Andrew Berg. I'm one of the other co-founders of Sketchy along with Saud. I went to med school with Saud at UCI where we studied together, starting really since the first year, and where we started sketching these crazy drawings together. And after that, went to Northwestern for emergency medicine residency, stayed on there for a few years, doing a fellowship in artificial intelligence, and then rejoined Sketchy after finishing that. I'm back in California. I work clinically in emergency medicine at Kaiser in Northern California, and just have an awesome time kind of balancing the two, working with Sketchy and working clinically. It's been quite a dream. So excited to be here.
Awesome. So quick agenda for today. We'll talk about clinical reasoning and sort of why we think it's important and why we actually think it's getting more important. We'll talk about what DDX is and kind of how it came to be, and then we'll show you DDX and walk you through a case, then talk through some quick tips for how you might use DDX in med school and kind of how to get to it. And we'll end with some giveaways. Brenda has some pretty sweet stuff to hand out. And happy to take questions sort of along the way, and we'll certainly save time at the end for questions as well. And in fact, we already have one question, wondering if we'll get a recording. Yes, this is being recorded, and I think Brenda will have a link for you at the end. So guys, clinical reasoning, what's it all about? So we talk a lot about clinical reasoning here at Sketchy and have been for a long time. And so, there's some points on there, but curious for your thoughts on sort of why this is really important for students to master and get better at, and sort of how you see the world of medicine and medical education changing to make this even more important.
I could jump in for a moment here. So I remember, going through the first 2 years of med school, all classroom based. We had some, preparing that we did for seeing patients, but once I was in third year, I really just kind of got thrown into it. And I felt like there wasn't like a great transition. And I remember early on trying to get better and better at, being able to see patients, ask the right questions, building a differential, but there wasn't really like a way to practice unless I was like out of rotation and like screwing it up. So we obviously all get better over time, and I wished I had something like this to practice, but back then the tech wasn't really there. So this is sort of, I think, one of the core reasons we built this. It was how can we give you all a realistic way to get the reps in, see patients, and learn all this stuff. So when you're actually in the clinic or in the hospital, it's just a lot more valuable for you, because you've got a lot of practice in. And I think it matters, obviously, when you're a practicing physician, you're seeing patients. So this is like, I think, the core of why you're on med school anyways. So yeah, it's a bit of my 2 cents on that.
Andrew, you got some thoughts on clinical reasoning?
Sure. I mean, I think a lot of what Said said is right. I remember, the transition is really a completely different way of thinking about things. First and second year for us, it was just about thinking about the diseases and all of the microbes in the farm as like these separate buckets. And it flips it when you have to think about the patient and they're presenting complaints and deducing from there. And it's something where while you're going through it, I think you get frustrated, or at least I got frustrated and found it was difficult. Didn't really exactly know why it was such a paradigm shift. And I think having to go in, interview patients, oftentimes where you're not being supervised, where you don't get immediate feedback, but where you're just kind of holding on to these thoughts and loose ends that you're trying not to drop. And it can be pretty challenging. And I think one way to really get good at it is to just have enough reps and getting enough practice in. And so that happens naturally throughout training. But I think with something like DDX or with any of these, virtual simulations that allow you to get reps in more quickly, I think could be a huge benefit. And it's something I wish I had too. So yeah, I think a lot of what Saud said, but yeah.
Totally. Yeah, I remember that feeling of sort of first getting into a room with a patient and having to ask them all these questions and trying to remember what is the sort of order of the history that I'm supposed to take, and also I'm supposed to remember my differential, and also I have to remember to be like super empathetic and polite, and like putting all of that together all at the same time for the first time is it's really hard. And so having a way to practice that, or sort of, as you said, kind of get reps at that, I think is super valuable. Um, and how do you see, we saw step one go pass fail. There's sort of a greater emphasis on step two and rotations now in medical school. How do you see sort of the rise of AI in medicine kind of affecting the need for clinical reasoning and sort of how we think about ourselves as physicians?
Yeah, that's that's a big question. I think um, in the immediate term, because I think the long term is hard. It's hard to talk about with this. I think it could go a number of directions, but uh, a lot of us are excited in the short term about AI's ability to help create better doctors. There are risks, of course. As we rely more and more heavily on AI for note taking and to be, their bedside, I think that provides some challenges and maybe could work against creating amazing doctors. But I think uh, products that help focus on us honing our skills rather than, just all of the shortcuts, I think it really is something that could be good for society and good for us. And so I think these are the types of products that are really exciting. And in the short term, I think a lot of faculty are really looking into these and are excited about it for good reason. I think it resonates with all of us who are practicing now that we wish we had more one-on-one direct feedback and advice that was honest and hopefully AI can help provide that. Yeah, I'm not bashing, by the way, AI as a as a shortcut and as an assistant. I use it every day now, unfortunately, and it does help. But there are a lot of risks. It's not perfect, and so that's why I'm a little bit reserved.
Totally. Yeah, I mean, I think that as those tools grow ever more prevalent, and as you said, there are many real benefits to using them. I think the emphasis on critical thinking and on sort of our simple humanity, I think, becomes more important. And so having a way to kind of practice those interactions again, I think is super valuable. Cool. Yeah, Brennan, you want to move on so we can talk about what it is, and maybe also as you guys are describing sort of what DDX is, you can talk a little bit about how it came to be.
Sure. So, so the way we design, so actually the way we initially started using AI, well, me personally, I so in emergency medicine you have to take oral boards, and with oral boards, which you don't know, it's kind of weird. You like sit there and somebody just talks you through a case, and you just have to like ask for things and work through a case. And because of COVID, mine was delayed and I didn't have anybody to practice with. So I practiced like this. I like put it into an AI, put in cases, and I like made it test me. Um, and miraculously I passed. And kind of showed it to Andrew and some of the folks on the team. And we had this idea to plug it in kind of at the med school level. And so that was kind of where it started. We changed the product a bit where it wasn't like oral boards based, but just more of a realistic patient based encounter, which I think is actually a better experience, probably more important anyways. Um, so that was a little bit of like where the idea came from. You know, you could now test yourself in a very realistic way, work through a case as many times as you want. And the AI is now like making up the cases. So what this is we are writing these cases. We create these characters and then you go through these cases step by step. So you'll see a patient and you get to take a history. And Andrew had mentioned, you know, in real life, you're not getting this instant feedback, but while you're learning, we are giving you instant feedback on uncovering questions that are, you know, important or like information that was important. So you're getting some feedback along the way that you're uncovering and like asking the right questions. And you kind of go through this interactive case. So then you'll do a differential with the attending as if you had like, you know, would do in real life. You get to do things you wouldn't do in real life as a med student, where you can actually like manage the patient and like order their meds. Um, and that piece of it we really wanted to add because it's good to get that practice, and two, that's what's on your board exams, right? On shelf on step two, it's always about like what's the next best step, the treatment and so on. So we tie that into this. So really, I think it's going to be better to just show it to you all, which we're going to do in a couple slides. But we just kind of wanted to give you a little bit of an understanding of like where did this come from, how does it work, what is AI doing, and you know why did we do this? It's currently being used at a few different schools for some in the preclinical years to get folks ready for clinical, and some are actually using the clinical years to augment some of the learning they're doing. Um, so yeah, I don't know if you guys want to add anything at this juncture before we do like an actual demo.
No, that was great. Actually, Brennan, if you want to go to the next slide, maybe Andrew, if there's anything else to add sort of on why you might want to use DDX as a student.
Yeah, I mean, I think we've talked a lot about the bridge, getting early exposure before starting maybe third year, or getting into clinical rotations. That was, I think, the big need that students identified and faculty have identified. But beyond that, I think the way I would use it is I would want at least a few practice cases, especially when going into rotations that have, I'd say, less typical types of presentations, maybe some conditions that you might not be quite as familiar with or haven't gotten as much exposure to in preclinical years. So like thinking peds, OBGYN, being able to go see those patients, kind of practice your presentation, making sure that you're doing a thorough history. That would, I think, be super helpful. And then for all of these rotations, there are the zebras and there are the rare can't miss cases that you're probably not going to see on rotation, that we have, you know, in the library. And I think those are awesome to work through. And nothing really replaces having a patient that's really sick and having one of those rare conditions. It really fixes it in your memory. if you get a question on the boards, or on your shelves, you can really just picture that case and hopefully answer the question. And this is not going to be better than that, but hopefully it can help get close to that. You have had practice seeing these tough cases or these rare cases. And so when you actually get questions on them, I think you'll be more prepared.
Awesome. So before we get to the actual demo, I just want to talk about two quick, the two different types of cases that we sort of broadly speaking have in DDX, since we'll only get to go through one case today. Yeah, so Brenda, if you don't mind hitting the next. Oh. So we have what we sort of think of as traditional cases, which are sort of the typical way that you'd walk through a case in a PBL or with an attending, where you go to talk to the patient, you take their history, you do their exam, you think about the differential together with your attending, you talk through some workup, and you manage the patient's condition. And so those cases kind of take you through that full trajectory, and you start out much as you would in real life with just a chief complaint, and you sort of have to think about your differential and make your diagnosis based on what you learn from the patient and learn from your workup. And then the other type of, I don't even necessarily want to say case, but the other type of experience that we offer in DDX, Brenda, if you want to go to the next slide, is what we call games. And so there's sort of a bunch of different types of these. We have tons of ideas here, and we'd love to hear your feedback on these games, but they range from sort of a boot camp where you practice reading chest x-rays or practice EKGs or lab interpretation. We have something called Guess TI, where your friend is texting you about an uncomfortable problem, and you sort of have to work them through it and work them up via text message. We have Guess the Bug, where you're given a little bit of information about a patient and have to identify the microbe and then the appropriate drug to treat that microbe with, as well as a few other types of cases. So these games are meant to be much shorter, a little more fun, perhaps sketchy in flavor, but still get you some really valuable information and some good practice. And with that,
Demo time.
demo time. You'll see this. Cool.
Yeah.
So this is our case library. As you can see, it's just right here in Sketchy. So if you already have a Sketchy subscription, just click on over to cases and you'll be able to do any of these cases. And I'll just give you sort of a really quick run through, but you can see, excuse me, some of those games that I mentioned, and then a whole passel of those more sort of traditional case types that you can walk through again to get those reps, get that practice that Andrew and Sid were talking about. So we're going to walk you through our very most favorite case, Mr. Michael Jones, a 52-year-old man with chest pain. And so to begin the case, you're asked to take a history by talking to Michael, just as you would with a standardized patient or with a real patient. So Simon and Andrew will kind of walk us through the case here, but feel free to throw some suggestions for what we might ask or what you want to find out in the chat.
Well, Ben, why don't you go ahead and you want to just talk to the patient a bit?
Yeah.
So we'll send a few messages and then we'll kind of explain what's going on here. And if anybody wants to make Ben type something, you can All right. So you see here, and I know we got a question about like how is it different than aquifer. So you can see it here. So a lot of the clinical case material that you might have used before is pretty passive, right? You read the history, you don't have to get it. Here it was just open-ended, and you can just talk to the patient pretty naturally, ask things in any way that you want to ask them, and just have this conversation in like a pretty snappy way. you've got these key findings that are popping up. And one of the ways you can think of this is one, when you're actually practicing, like these are actually like very important things that you should pick up on. But like even when you're doing an OSCE, for example, there's always someone that's like grading you, right? And like checking like did you ask the right things? Do like key actions? That's how you could think about these key findings. It's like you've got this AI that's like grading your history or whatever step you're on. And we've set like what these critical things are that you should have found out or should have done. Um, and then the patient is like a completely separate AI that just knows the story. So we basically created this case. The AI is not making things up. It's not making up the case. We created it, and we created Michael Jones, and now he's just acting, and he's like your SP. And that's kind of what's going on here, and it gives you this realistic experience with enough feedback where you're like learning and engaged. And it's not like super open ended, but open ended enough to like have have a learning experience. That's not like super passive like some of the other case based learning you might do. And in all of these cases, so we've got a group of physicians that we work with. Um, and so they're writing these cases, and it's kind of dependent on like what specialties they are. So they're all practicing generally at teaching hospitals, and they like set aside time with us to write cases. Um, and that's where kind of all this content is coming from. So we really wanted this to be like a trusted source of content as well uh, for you all as users.
Yeah, so as you know, I've gotten, well, I'm cheating because I I know this case, but I've gotten a bunch of these key findings here just to kind of illustrate how that goes. Um, One thing that we sort of have learned from watching students play through this is that often if you get down to that last star, it can be a little bit tricky to remember uh, what you haven't asked about or sort of where you should go. And so we give you a little help with that as well. And you can ask for a hint. Um, so when I was sort of going through my old cards very briefly before, I didn't ask about radiation. So I can ask him about that. And then I'll find out that, great, I've gotten sort of all the key findings here. Anything else on this, guys, before we move on to the exam?
Yeah, I mean, I guess one thing to add is, you're gonna have the cases where you get to the end and you're gonna realize that you never asked this guy, if he smoked or about like family history. Uh, Actually going through the case and experiencing that and then missing that and realizing it, I think is a good way to actually like cement it in of like I have to remember to ask about that every time, someone's coming with exertional chest pain. And then when you actually see someone in the clinic who's like has the same thing as Michael Jones, you're not going to forget to ask that question. Um, so that's why we've kind of made it in this way where you have to like uncover these things. So just like a little bit more valuable and kind of help you remember, if you ended up missing one.
Awesome. I'll quickly talk through the exam because I don't think there's that much to say for this step. In our cases, we tend to do the exam in one of two ways. So one is like this, where this exam is pretty benign. This case is sort of more focused on the back half of sort of some lab interpretation and management. And so we just tell you the exam, and you can look through it and see if there's anything that particularly stands out to you as pertinent for this patient. If we want the exam to be a more central piece of the case, if there's a particular exam maneuver we want to make sure you're thinking about, we make this an interactive conversation, much like that patient conversation where you're talking to the attending physician and you sort of talk through different exam maneuvers and what the findings would be, which I think, Syed, is pretty close to how it works in those oral boards still.
Yeah, like if you say like, let's say they have crack cold or something, if you say pulmonary, they'll ask like, okay, what do you want to know about it? And you have to ask for like crackles. Depending on the case, like we have some advanced cases, some are easier where you just get it. So yeah, it just kind of depends which case you're doing. Sometimes it's modeled that way.
Cool. So we'll move on to the differential.
What are you thinking, man? You're in the hot seat.
I'm a simple urine doctor, you know. I'm not an emergency doc. But look, I know enough to think that this, he's got chest pain radiating to the left arm. He's got an important cardiac history, family cardiac history. Exertion, it's worse with exertion and improves with rest. So I'm going to say acute coronary syndrome is my first differential here. So I kind of already did this, but Dr. Reed will ask me to justify this. What did I learn about this patient that makes me think ACS is the right diagnosis? All right. I've now reached my capacity of emergency medicine diagnoses. What do you think, Andrew?
Well, I mean, we could try something that it's definitely not like asthma, to
Oh
see
yeah,
if,
we should. Yeah, that's good. Let's do urologist guess. Let's say like anaphylaxis. So again, I think one thing that we think is really special about DDX is that it provides this teaching. So it's not just sort of a way to input answers and then get a score back. It actually gives you this feedback. Um, and certainly, I think preparing for or accounting for correct answers um, is important, but is also relatively speaking easy. The sort of world of correct answers is fairly limited, but the world of wrong answers is pretty significant. And so being able to sort of correct you or help you think about things in a different way based on your specific sort of misunderstanding, I think is really powerful here.
Yeah, and this step is also trying to mimic for you. Well, your third year, right? You go in the room, you see the patient, you do the history, physically come out, and your attending is literally asking you the same exact question. Now you'll have the practice and some of the answers if they're drilling you on why. The other nice thing about this step, there's more than three that are possible. Um, so this kind of gets you that practice of like maybe you're thinking of the same few. When you get to the end, you could see kind of a longer list of things that you could have also thought about that maybe you didn't consider. So just over time, you get the practice of, building just like a broader differential and keeping everything in mind.
I threw in another one from Emily in the chat, who's going to make a great emergency doctor or whatever kind of doctor you want to be someday.
All right. Shall we
Awesome.
proceed?
Yeah, let's keep going.
So
So again, as you sort of work through these cases, you'll see that each step gets handled in a different way depending on sort of the emphasis of the case. In this case, again, because we want you to focus on some EKG interpretation and the management of this patient, we have Dr. Reed tell you what orders she's going to place. In other cases, you would go back and forth with the attending about, okay, you said acute coronary syndrome. What do you want to do to work that up? And you'd sort of have that, again, that classic conversation that Saud was talking about, okay, there's your differential. What are you going to do for it? Here, we ask you to read an EKG. I'll pull that up and make it a little bigger. If anyone wants to take a second in the chat and throw us an EKG read, that might be a tall order.
yes, again, recreating that bedside interaction. And again, you're going to get a lot of EKGs on kind of all your exams too. You're reading them for the rest of your life. So the more you get to read, the better. Um, and it's different when it's just open, right? There's no choices here. You gotta say something, stick with it. So
Yeah.
you get in that practice here.
Yeah. One thing I particularly like about this, which I think, again, with the goal of sort of getting those reps and building those good habits, is you can't just do the sort of knee-jerk thing you want to do and say, that looks normal to me. We really want you to go through it somewhat systematically and think about how does the rate look? What's the rhythm look like? Are there segmental changes and so on? Um, so, you would talk through each of those. I think we just asked for rate, rhythm, and segmental changes here. But it's a good reminder that even if there's something glaringly obvious on the EKG, you should be systematic so that you don't miss small details.
Yes, that was a normal one.
So our friend Mr. Jones here started to have some more chest pain. And Jay Clark, who's the nurse taking care of him, just paged us. He still had the EKG hooked up, so they ran another one and they got this. Andrew, would you be happy if you saw a patient with this come in?
Yeah, and all of a sudden it's black and white, so you know something's wrong.
Right. It was pink and now it's blue. That's bad.
Yeah, I mean that is pretty obvious STEMI there.
Yeah, so here, because now we're in a slightly more sort of emergent situation, we don't make you do that systematic read, though we could. But now I think, like Andrew and Saud were talking about before, we sort of give you the opportunity to do something that the med student doesn't often get to be in charge of, which is, what are we going to do to manage this patient?
And again, this is a vague, what action should we take next is vague and open-ended, just like real life. So yeah, cath lab's a good answer. Are there any other steps as we're thinking about going to the, I'm a urologist. Yeah, are there any other steps before rushing off to the cath lab? I.e., any meds we'd want to give, or any maneuvers, or any. And these small things are the most tricky when making the transition. Like, oh, let's make sure that they have an IV. Let's make sure that they've gotten their baby aspirin. Yeah, heparin's great.
So, yeah, we're getting there.
Put the patient on pads. I'm not sure if that we made that a key finding or not, but why not?
Uh, I think that, so, well, one thing is this guy's probably a little uncomfortable, so let's get him some pain control.
That'll
And
trigger.
I think this is actually this is kind of goes. I mean, Andrew, you gave them IV access, but I think that's one of those things that you forget, that patients don't just walk into the hospital with a line ready to go, and much the same way they don't
Oh,
walk in the
monitors.
monitor.
Yeah, that's there we go.
Awesome.
I think we saved him. I
Yeah.
think it's gonna be all right. It was really the thing I did though. The urologist calling the cath lab, that was the most important step.
Yeah. So people really have fun at this step. And you're working through the case, you get really like invested in it. So, some people get really nervous at this point. Want to save Mr. Jones. And in real life, you're not gonna be able to do all this, right? So as a med student. So we wanted to give you that practice in like a safe environment. This is more of like an ED case. There's some other cases where it's like not as emergent, but you still have to talk about like basically your plan, right? What you're gonna do for this patient now that you have a diagnosis. So even Ben can do it. He's a urologist.
Yeah, I'm basically worthless. Um, so we'll wrap up the case here with a couple multiple choice questions. Feel free to throw some answers in the chat and we'll go with what you tell us to go with.
So when you do board style questions, you read this long vignette and then you answer a question about it. In DDX, you lived the vignette, right? You went through the whole patient case, and now we're adding the questions attached to it. So we hope that this will kind of give you better practice for those types of questions and kind of connect it all together. All right, we've got some answers rolling in. I think we have quorum here. You gonna
Yeah,
go
we got a couple votes for
C?
A and I think a few more for C. So let's go with C. What's going on? Let's go with C. Nice, good work.
Boom.
Yeah, so anterior leads. Got ourselves an anterior STEMI. All right, let's do another one. Now we're throwing it way back to farm here. So how does heparin work?
Sketchy Farm. Who remembers?
Right.
We got
Got some
four B's.
I'm seeing some B's and some C's. Looks like the B's have it. Let's go with B. Antithrom that's what I'm talking about. That's right. Perfect. Yeah, so heparin activates antithrombin. All right, we got two more of these. So this is a cool sort of complication. I shouldn't say cool, but an interesting case of a complication post-MI. Oh, we got a nice mix here of D. It looks like some B's and D's. I don't even know which one's more. You want to put your thumb on the scale? Should I put my thumb on the scale?
I think you gotta call it.
I
You're the
think B's
driver.
have
I
it.
called it.
Uh,
Go with B. Yeah, so this is a ventricular septal rupture. And last one. So this is a sort of a slightly different scenario, but a good reminder that there isn't like one single concept of MI, and these patients uh, with occlusion of coronary arteries can present in different ways.
And we've continued to add cases, so it's not like, you saw the one MI case and you're done. You might get another one, you might get a different one. But we also try to mix it up in the questions just to give you a mix.
Seeing a lot of B's here. I'm going to go with B. Nicely done. Awesome. So to round out the case, usually we tell you a little bit about how the patient did, what was their sort of outcome and long-term care. And then we put in some learning points here that we and the faculty member that wrote the case think are really important for you to remember, something that you can kind of hang on to after the case, whether that's clinical pearls or particularly important criteria or whatever it might be. And then at the very end of the case, you get your score. And we crushed this one, to be honest. We did great. You can sort of go through and see what were the other conditions that you might have said for the differential, what were the findings on that normal EKG, and then I think we got all the management steps, yeah. And then you can go back and, if you got one wrong, review the questions as well. And if you're going through these cases, we'd love your feedback. We want to hear how this helped you sort of think clinically. We want to hear your opinion of the case. And we really, really, really love this written feedback down here at the end. We read all the comments. We sort of go through them all the time and make tweaks to the cases, make updates. And if you have nice things to say, we like those too. All right, Brenna, I will throw it back to you to round out the slides. Awesome. So one thing we get asked a lot is, how should I use DDX? What should I do with it? Andrew and Said, you both kind of talked about how you would have liked to have a tool like this to get reps to practice on rotations. I think Andrew, you even said like doing a couple of cases of sort of rare things at the beginning of a rotation. But curious how you guys would recommend using DDX.
Yeah, I mean we've broken them up by rotation. And they could see that side of it, right? It's not just the faculty.
Yeah, so we don't tell you per case what rotation it's from, but you can filter to a set.
You can filter it.
Yeah.
Yeah. So if let's say you're starting a rotation, you could filter into the one you're on and get through, that collection. Maybe even like at the beginning of the rotation or like right before it, so you're prepared. What's nice about these cases is you can revisit them as well because you might have forgot some things. But yeah, I think going through rotation by rotation is one way to do it. Or you could mix it up completely so you're not like getting any hint as to like what it might be. But yeah, I think 1 to 2 cases is a week is a good amount. Because as you saw, there's a lot in the case, right? And even at the end, there's like things to read about it. The questions you might have done, you might like go read more about that. So I think it's about like getting that one disease process that you just learned about and then spending some more time with it afterwards to really drill it in is worthwhile. It's not like something you want to just like rush through and do like multiple cases in one sitting.
Awesome. And I think this is our last slide before the giveaway. But I think when I was in med school, at least, I'll make this an I story. I don't feel like I ever really learned how to do this process. It was something I just kind of learned through trial and error or experience. And particularly for the two of you who, where emergency medicine, this is actually, for urology, everybody comes in diagnosed and you're just sort of managing their condition. But for you guys, people come in telling you what hurts and then you got to figure it out. So curious kind of how you think through the process of building a differential and sort of arriving at a diagnosis.
Yeah, I could add. We do this in some of the cases too, where ideally you see the patient and whatever information you get, like the triage note, or let's say their last clinic note or their last inpatient note or whatever it might be, and if you're still trying to like figure out what's going on, you kind of have a differential before you walk in the room, right? Of like these are the things I'm thinking about, and then as you ask the questions, um, that's kind of helping you narrow it down or like figure out which one might be more likely, and that's going to lead to what you want to test, right? Um, so and in the history, we actually have like a limited number of questions because we do want to get you towards like being thorough and efficient. Um, so you don't want to be like scattered. You want to like ask directed questions based on kind of this differential that you started with. But always kind of keep it broad so you don't miss anything. And there's always going to be questions that you need to ask to like rule out, badness. Andrew, not sure if you want to add anything. I think
No,
you've seen
yeah.
patients the most recently,
Yeah,
so
yeah.
let's get some of your wisdom.
Yeah, no, I mean, I think a big part of it is practice. And I think you want to fight the early closure bias of when you first hear a few words that you're looking for, shutting out prematurely some other important diagnoses. Literally this past week, I know this sounds not real, but I had an in-flight emergency, and I remember I was a little bit late to showing up because I was like asleep when it happened, and showed up, and yeah, I mean, it was a young woman who was fainting and didn't look great, but the other doc that was on there was like, "Oh, this is vasovagal," and I'm like, "Well, have you asked have you asked any questions, gotten any history yet, or is that just what you want it to be?" And so, and I think in situations like that where you have nothing, it really is a good reminder to keep your mind open to other ideas. And yeah, the doctor was 100% right. It was just vasovagal. But it's good to not jump to conclusions too soon. And so this helps really force you to do that with the key findings. It really incentivizes you to stick to a structured exam or a structured interview, but as the cases get more advanced, they'll make sure that you're not forgetting a lot of the details too. So yeah, I think we kind of all want to, especially with imaging and EKGs, we want to just jump to the diagnosis and move on, but you miss things that way. And so this helps reinforce that.
Wisdom from the front lines. Yeah, so happy to take some questions here, and I think Brenna might have some other stuff for you as well. Nick had a great question. Could you speak to how you prioritize which cases to develop thus far, most commonly tested material on boards, most common diagnoses seen clinically, most confusing, some combination thereof? Yeah, I don't know if you guys want to take that, or happy to answer it myself.
Yeah, I mean, at least initially, we definitely wanted to have coverage across the different systems and rotations. So one, it was like, let's get a broad coverage. And then we did want to look at kind of it was a combination of things that are almost like, if you're on this rotation, like you should see this case, right? And should know this case. You're going to get tested on the case. It may or may not be common, like in aortic dissection, for example, is not common, but you should know it very well, as an example. So we kind of had these different uh, dimensions, and then we actually worked with the faculty who help us write cases to help rank those to come into like the priority of which cases to write. And that's kind of how we started. And now we have the privilege of like people actually using this to kind of further develop that list, but that was where we started.
Yeah, and we focused on which competencies are super important for each rotation, like interpreting blood gases or interpreting EKGs, chest x-rays, and making sure that we're picking cases where we can build those competencies. Great question. So as a first-year med student, what should my approach towards practicing clinical cases be? And I think this goes back to what I was just talking about, which is sticking and really getting comfortable with the structured interview and not forgetting all of those details, because they are important. So just going through, getting practice, and getting comfortable, having an interview, veering off course and then getting back on course, and just that. I think having those repetitions will allow you to be more comfortable at the bedside.
The other thing I'd say is don't be afraid of the hints. I think as medical students, we sort of are trained to treat like aids like that as cheating or something. But the hints are really meant to, I mean, especially for a first year where you may not be able to flesh out your differential diagnosis, or you may not know all the right questions to ask. The hints are really there to sort of help you through the case and help you maybe tackle a case that you couldn't otherwise. So don't be afraid of the little pink button.
And so just a few other things quickly. So the case we did here, it was all typing. We have a feeling students will mostly want to just type, but we have the ability for you to talk to patients too, and have just a natural voice-to-voice conversation, and which can be fun, is more realistic, maybe makes you think a little bit differently. And that we'll be expanding that, going forward. So that's an option. We'll be leaning more into the management and really making the cases more realistic and exciting, to kind of put yourself in the role of being a senior resident or as an attending and making those key decisions. And so as we start making some of these changes, we'd love to have feedback. Like as you're going through cases, if you find, something we do a little bit more tedious, definitely let us know. Or if you like something, let us know. Or if you want to practice certain skills like, CT interpretation, please give us that feedback. It'll be really helpful. And we do take all of this feedback seriously. We all talk through all of the feedback, so it's not going to fall on deaf ears.
In future cases, can we choose the level of difficulty for the same case? That is definitely something that we would like to include. You can't choose the level of difficulty per case right now. What we will be adding, I think in the next couple of weeks, is an indication of how difficult the case is before you start it. And you'll be able to filter by if a case is more an early or an advanced case. And so you can kind of tune it to where you are in school, or if you want to, jump ahead or try something harder, you can do that too.